Rapid Review First Aid Usmle Step 1 2025 35th edition. What is osmotic demyelination syndrome? Osmotic demyelination syndrome. When rapid osmotic changes occur, most commonly iatrogenic correction of hyponatremia, but also rapid shifts of other osmolytes like glucose, causes massive axonal demyelination in pontine white matter. What is acute inflammatory demyelinating polyneuropathy, also subtype of Guillain-Barré syndrome? Autoimmune destruction of Schwann cells via inflammation and demyelination of motor and sensory fibers and peripheral nerves, likely facilitated by molecular mimicry and triggered by inoculations or stress. Once again, acute inflammatory demyelinating polyneuropathy, which is a subtype of Guillain-Barré syndrome. Autoimmune destruction of Schwann cells via inflammation and demyelination of motor and sensory fibers and peripheral nerves, likely facilitated by molecular mimicry and triggered by inoculation or stress. Next, what is Charcot-Marie-Tooth disease? Defective production of proteins involved in the structure and function of peripheral nerves or the myelin sheath. Next, progressive multifocal leukoencephalopathy is destruction of oligodendrocytes secondary to reactivation of latent JC virus infection causing demyelination of CNS. Progressive multifocal leukoencephalopathy is destruction of oligodendrocytes secondary to reactivation of latent JC virus infection causing demyelination of CNS. Next, what is Sturge-Weber syndrome? Sturge-Weber syndrome is somatic mosaicism of an activating mutation in one copy of GNAQ gene causing congenital anomaly of neural crest derivatives. This leads to capillary vascular malformation and ipsilateral leptomeningeal angioma with calcifications, also episcleral hemangioma. What is Sturge-Weber syndrome? Sturge-Weber is somatic mosaicism of an activating mutation in one copy of the GNAQ gene. This leads to congenital anomaly of neural crest derivatives. This leads to capillary vascular malformation and ipsilateral leptomeningeal angioma with calcification and episcleral hemangioma. Next, what is pituitary adenoma? Pituitary adenoma. Pituitary adenoma is hyperplasia of only one type of endocrine cells found in pituitary, most commonly from prolactin producing lactotrophs. Next is what spinal muscular atrophy? What is spinal muscular atrophy? Spinal muscular atrophy is congenital degeneration of anterior horns due to SMN1 mutation. This leads to defective SNRNP assembly, leading to LMN apoptosis. LMN apoptosis. Next condition is amyotrophic lateral sclerosis, is combination of upper motor neuron and lower motor neuron degeneration and familial form associated with SOD1 mutation. SOD1 mutation. SOD1 mutation, ALS, amyotrophic lateral sclerosis. Next condition, Tabes dorsalis, degeneration or demyelination of dorsal columns and roots in tertiary syphilis leads to progressive sensory ataxia, impaired proprioception, leading to poor coordination. Next, what is poliomyelitis? Poliomyelitis is poliovirus infection spreads from lymphoid tissue of oropharynx to small intestine then to CNS via bloodstream, leading to cell destruction in anterior horn of spinal cord, eventually causing lower motor neuron death. Anterior horn of spinal cord element death is caused by poliomyelitis. Anterior horn of spinal cord, which is lower motor neuron death in poliomyelitis. Next condition is Friedreich ataxia. Friedreich ataxia is trinucleotide repeat GAA on chromosome 9 in frataxin gene also called iron binding protein. This leads to impaired mitochondrial function, causing degeneration of lateral corticospinal tract, spinocerebellar tract, dorsal columns, and dorsal root ganglion. Again, Frederick ataxia, trinucleotide repeat, GAA on chromosome 9 in frataxin gene, causing iron binding protein, leading to impaired mitochondrial function, degeneration of lateral corticospinal tract and spinocerebellar tract, causing dorsal columns and dorsal root ganglia. Next condition is noise-induced hearing loss. Noise-induced hearing loss causes damage to stereociliated cells in organ of Corti, leading to loss of high frequency hearing first. So high frequency hearing first, lost in noise-induced hearing loss. Next is presbycusis. Presbycusis, age-related progressive bilateral symmetrical sensory neural hearing loss, often of higher frequency due to destruction of hair cells at the cochlear base. At the cochlear base, destruction of hair cells at the cochlear base, presbycusis. What is cholesteatoma? Cholesteatoma is abnormal growth of keratinized squamous epithelium in middle ear. Keratinized squamous epithelium in middle ear. Keratinized squamous epithelium in middle ear. Primary from tympanic membrane retraction pocket, secondary from tympanic membrane perforation, secondary from tympanic membrane perforation, secondary from tympanic membrane perforation. Next is Meniere's disease. What is Meniere's disease? Meniere's disease is increased endolymph in inner ear, causing vertigo, sensory neural hearing loss, tinnitus, ear fullness. These are the things in Meniere's disease: increased endolymph of in inner ear, vertigo, sensory neural hearing loss, tinnitus, ear fullness. What causes hyperopia? Hyperopia, eye too short for refractive power of cornea and lens. This is a cause of hyperopia, eye too short for refractive power of cornea and lens, leading to light focused behind retina. Hyperopia. Next condition is myopia. Myopia is caused by eye too long for refractive power of cornea and lens. Myopia is when eye is too long for refractive power of cornea and lens, leads to light focus behind the retina. Light focus behind the retina. Sorry. Myopia is eye too long for refractive power of cornea and lens, light focused in front of retina. So front of retina is myopia, behind the retina is hyperopia. What causes astigmatism? Irregular symmetric curvature of cornea or lens, causing different refractive power at different axes. Astigmatism is irregular or asymmetric curvature of the cornea or lens, leading to different refractive power at different axes. Next condition is presbyopia. Presbyopia, age-related impaired accommodation, likely primarily due to decreased lens elasticity. Presbyopia is age-related impaired accommodation, likely primarily due to decreased lens elasticity. What causes glaucoma? What causes glaucoma? Optic neuropathy, causing progressive vision loss, first peripheral, then central, usually with increased intraocular pressure. Increased intraocular pressure. Next, open angle glaucoma. Open angle glaucoma associated with increased resistance to aqueous humor drainage through trabecular meshwork. Open angle glaucoma, increased resistance to aqueous humor drainage through trabecular meshwork. Next is angle closure glaucoma. Angle closure glaucoma is anterior chamber angle narrowed or closed. Anterior chamber angle is narrow or closed, associated with anatomic abnormalities. Example, anteriorly displaced lens resting against central iris. Anteriorly displaced lens resting against central iris, leading to decreased aqueous humor through pupil, increased pressure in posterior chamber, leads to peripheral iris pushes against cornea, leading to drainage pathways obstructed by iris. Angle closure glaucoma is caused by anterior chamber angle narrowed or closed, associated anatomic abnormalities. Example, anterior displaced lens resting against central iris, leading to decreased aqueous flow through pupil, increase pressure in posterior chamber, leading to peripheral iris pushes against cornea, drainage pathways obstructed by iris. Next condition is diabetic retinopathy. Chronic hyperglycemia, increased permeability and occlusion of retinal vessels, microaneurysms, hemorrhage, non-proliferative, retinal neovascularization due to chronic hypoxia, which is proliferative. So two things, non-proliferative and proliferative. Non-proliferative is hemorrhage and proliferative is neovascularization. Neovascularization due to chronic hypoxia. What causes hypertensive retinopathy? Hypertensive retinopathy is caused by chronic hypertension causing spasm, sclerosis, fibrinoid necrosis of retinal vessels. Hypertensive retinopathy is chronic hypertension leading to spasm, sclerosis, and fibrinoid necrosis of retinal vessels. What causes retinal artery occlusion? Retinal artery occlusion is central or branch retinal artery blockage, usually due to embolism, carotid artery atherosclerosis, more than cardiogenic. So, retinal artery occlusion is central or branch retinal artery blockage, usually due to embolism, carotid artery atherosclerosis, more than cardiogenic, and also less commonly due to giant cell arteritis. What causes retinal vein occlusion? Central occlusion due to primary thrombosis and also branch occlusion due to secondary thrombosis at arteriovenous crossings. What causes retinal detachment? Retinal detachment, neurosensory retinal separates from underlying retinal pigment epithelium, leading to choroidal blood supply loss, causing hypoxia and degeneration of photoreceptors due to retinal tears, rhegmatogenous or tractional or exudative fluid accumulation, non-rhegmatogenous. Rheg- Rhegmatogenous is retinal tears, and traction exudative, which is fluid accumulation, is non-rhegmatogenous. What is retinitis pigmentosa? Retinitis pigmentosa, progressive degeneration of photoreceptors and retinal pigment epithelium. Degeneration of photoreceptors and retinal pigment epithelium, retinitis pigmentosa. What causes papilledema? Papilledema is increased intracranial pressure secondary to mass effect, impaired exoplasmic flow in optic nerve, optic disc swelling, usually bilateral. Papilledema is increased intracranial pressure secondary to mass effect and impaired exoplasmic flow in optic nerve, leading to optic disc swelling. What causes relative afferent pupillary defect? Marcus Gunn pupil. Unilateral asymmetric lesion of afferent limb of pupillary reflex. Example, retina, optic nerve. Horner syndrome. Horner syndrome is caused by lesion along sympathetic chain. First neuron is in pontine hemorrhage. Lateral medullary syndrome. Spinal cord lesion above T1 like Brown-Sequard syndrome or late stage syringomyelia. Secondary neuron is seen stellate ganglion compression by Pancoast tumor. Third neuron, carotid dissection. So once again, Horner syndrome is lesion along sympathetic chain. First neuron pontine hemorrhage, lateral medullary syndrome, spinal cord lesion above T1 like Brown-Séquard syndrome or late stage syringomyelia. Second neuron stellate ganglion compression by Pancoast tumor. Third neuron carotid dissection. Next condition is cavernous sinus syndrome, secondary to pituitary tumor effect, secondary to pituitary tumor mass effect, carotid cavernous fistula or cavernous sinus thrombosis related to infection, spread due to lack of valves in dural venous sinus. Lack of valves in dural venous sinuses causes spread of infection, which is seen in cavernous sinus syndrome. What is delirium? Delirium is usually secondary to illness like CNS disease, infection, trauma, substance use, metabolic electrolyte imbalance, hemorrhage, urinary fecal retention, or medication. Example, anticholinergics. Next, what is schizophrenia? Schizophrenia is altered dopaminergic activity, increased serotonergic activity, decreased dendritic branching. Schizophrenia is altered dopaminergic activity, increased serotonergic activity, decreased dendritic branching. What causes distal renal tubular acidosis, RTA type 1? RTA type 1 distal renal tubular acidosis type 1 is inability of alpha intercalated cells to secrete H plus, inability of alpha intercalated cells to secrete hydrogen. So there is no new HCO3 or bicarb generated. This leads to metabolic acidosis. Proximal RTA type 2. Proximal RTA type 2 is defective PCT bicarb reabsorption. So there is problem in PCT, proximal convoluted tubule. So there is no absorption of bicarb, leads to increased urinary excretion of HCO3 minus and leads to metabolic acidosis. RTA type 4, hyperkalemic RTA type 4 is hypoaldosteronism or aldosterone resistance leads to increased potassium, decreased NH3 synthesis in PCT and decreased NH4 plus excretion, metabolic acidosis. Metabolic acidosis caused by hyperkalemic RTA type 4, hypoaldosteronism, aldosterone resistance, increased potassium, decreased NH3 synthesis in PCT, decreased NH4 excretion, and this leads to metabolic acidosis. Next condition is nephritic syndrome. Nephritic syndrome. Glomerular inflammation leads to GBM damage. This leads to dysmorphic RBCs in urine. This leads to hematuria, decreased GFR causing oliguria, azotemia, increased renin release. Oliguria, azotemia, increased renin release, increased renin release. Oliguria, azotemia, increased renin release. Nephrotic syndrome. Nephrotic syndrome is podocyte damage, leads to impaired charge barrier, proteinuria, hypoalbuminemia, increased hepatic lipogenesis, hypercholesterolemia, antithrombin loss, hypercoagulability, IgG loss causing infection. Nephrotic syndrome is podocyte damage, impaired charge barrier causing proteinuria, hypoalbuminemia, increased hepatic lipogenesis, hypercholesterolemia, antithrombin loss leads to hypercoagulability, IgG loss leads to infection. What is mixed nephrotic syndrome? Severe GBM damage, RBCs lost in urine plus impaired charge barrier. So there is hematuria and proteinuria. Next condition, infection related glomerulonephritis. Infection related glomerulonephritis. This is a type 3 hypersensitivity reaction with consumptive hypocomplementemia. So type 3 hypersensitivity reaction with consumptive hypocomplementemia. Next condition is Alport syndrome. Alport syndrome is type 4 collagen mutation, X-linked dominant, irregular thinning, thickening, and splitting of GBM leads to nephrotic syndrome. So, Alport syndrome is type 4 collagen mutation. This is X-linked dominant, and you see irregular thinning and irregular thickening and splitting of GBM. This leads to nephrotic syndrome. What is stress incontinence? Outlet incompetence, urethral hypermobility, intrinsic sphincter deficiency leads to leak with increased intra-abdominal pressure, and sneezing and lifting exacerbates stress incontinence. So, stress incontinence is outlet incompetence, which is urethral hypermobility, intrinsic sphincter deficiency, leak with increased intra-abdominal pressure, like sneezing and lifting. What is urge incontinence? Urge incontinence is detrusor overactivity. Urge incontinence is detrusor overactivity leads to leak with urge to void immediately. Leak to urge to void immediately. What is overflow incontinence? Overflow incontinence is incomplete emptying detrusor under activity of outlet obstruction. This leads to leak with overfilling. Leak with overfilling. Leak with overfilling. Prerenal azotemia. Prerenal azotemia is decreased renal blood flow leading to decreased GFR and increased reabsorption of sodium and water and urea. Sodium, water, and urea. Prerenal azotemia is decreased renal blood flow, decreased GFR, increased reabsorption of sodium and water and urea. What is intrinsic renal failure? Intrinsic renal failure is patchy necrosis, debris obstructing tubules, and fluid backflow leads to decreased GFR. This is intrinsic renal failure. What is post-renal azotemia? Post-renal azotemia. Post-renal azotemia is outflow obstruction and is usually bilateral. Next condition is adnexal torsion. Adnexal torsion means ovarian torsion, twisting of ovary or fallopian tube around infundibulopelvic ligament and ovarian ligament. This leads to venous lymphatic blockage. Arterial inflow continues to cause edema. Blockade of arterial inflow. Blockade of arterial inflow leads to necrosis, hemorrhage. Necrosis and hemorrhage. What causes preeclampsia? Preeclampsia is abnormal placental spiral arteries leading to endothelial dysfunction. Endothelial dysfunction causing vasoconstriction. Ischemia leads to new onset hypertension with proteinuria. New onset hypertension with proteinuria. Ischemia leading to new onset hypertension with proteinuria. What causes supine hypotensive syndrome? Supine hypotensive syndrome is caused by supine position, leads to gravid uterus, compresses abdominal aorta and IVC, leads to decreased placental perfusion, decreased venous return. Decreased placental perfusion, decreased venous return. Supine hypotensive syndrome, supine position causes gravid uterus to compress abdominal aorta and IVC, leading to decreased placental perfusion and decreased venous return. What causes polycystic ovarian syndrome? What causes this condition called PCOS, polycystic ovarian syndrome? Hyperinsulinemia or insulin resistance leads to altered hypothalamic feedback response. This leads to LH-FSH ratio, increase LH-FSH ratio, increase in androgens, increased rate of follicular maturation, and unruptured follicles. Cyst causes anovulation. What is functional hypothalamic amenorrhea? Functional hypothalamic amenorrhea. This is a severe caloric restriction condition where increased energy expenditure or stress leads to altered pulsatile GnRH secretion. This causes decreased LH-FSH estrogen. LH-FSH estrogen is decreased due to altered pulsatile GnRH secretion due to caloric restriction. This is functional hypothalamic amenorrhea. Next condition is varicocele. Varicocele is increased venous pressure, dilated veins in pampiniform plexus, enlarged scrotum, bag of worms. Enlarged scrotum, bag of worms. What causes methemoglobin? Methemoglobin is increased oxidized hemoglobin Fe3 plus, secondary to dapsone, local anesthetics, nitrites, and decreased oxygen binding but increased cyanide affinity. This leads to tissue hypoxia. So once again, methemoglobin is increased oxidized hemoglobin Fe3 plus, secondary to dapsone or local anesthetics or nitrites. This leads to decreased oxygen binding but increased cyanide affinity, and this leads to tissue hypoxia. Next condition is sarcoidosis associated hypercalcemia. Sarcoidosis associated hypercalcemia is caused by non-caseating granulomas. This leads to increased macrophage activity, increase 1 alpha hydroxylase activity in macrophages. This leads to vitamin D activation. And finally, increase in calcium. So the pathway of increased sarcoidosis associated hypercalcemia is you see non-caseating granulomas, which is increased macrophage activity leading to increased 1 alpha hydroxylase activity in macrophages, 1 vitamin D activation. This leads to increased calcium. Next condition is ARDS, acute respiratory distress syndrome. This is alveolar injury leading to inflammation, capillary endothelial damage, and increased vessel permeability, causing leakage of protein-rich fluid into alveoli. This leads to intra-alveolar hyaline membranes and non-cardiogenic pulmonary edema, decreased compliance and ventilation perfusion mismatch, leading to hypoxic vasoconstriction and increased pulmonary vascular resistance. Increased pulmonary vascular resistance. Alveolar injury leads to inflammation, capillary endothelial damage, and increased vessel permeability. This causes leakage of protein rich fluid into alveoli, intra-alveolar hyaline membrane, and non cardiogenic pulmonary edema, leading to decreased compliance and ventilation perfusion mismatch. This leads to hypoxic vasoconstriction and increased pulmonary vascular resistance. This is ARDS pathophysiology mechanism. Next condition is sleep apnea. Sleep apnea, respiratory effort against airway obstruction, which is obstructive sleep apnea, impaired respiratory effort due to CNS injury toxicity. CHF, opioid causes central sleep apnea. Obesity, hypoventilation leads to increased PaCO2 during waking hours. During waking hours, if there is increased PaCO2, that is because of hypoventilation, specifically because of obesity, hypoventilation. Next condition is gout. Gout, intellectual disability, self-mutilating behavior in a boy. This is called Lesch-Nyhan syndrome, HGPRT deficiency, X-linked recessive. If you see gout, intellectual disability, self-mutilating behavior in a boy, the diagnosis is uh, Lesch-Nyhan syndrome, HGPRT deficiency, X-linked recessive. Next clinical presentation is situs inversus chronic ear infection, sinusitis, bronchiectasis, infertility. The diagnosis is primary ciliary dyskinesia, also called Cartagena syndrome. Cartagena syndrome. Next clinical presentation is blue sclera, multiple fractures, dental problems, conductive slash mixed hearing loss. Diagnosis is osteogenesis imperfecta type 1 collagen defect. What is elastic skin, joint hypermobility, bleeding tendency? Diagnosis is Ehlers-Danlos syndrome type 5 collagen defect. Type 3 collagen defect seen in vascular subtype. Next clinical presentation arachnodactyly, lens dislocation upward and temporal, aortic dissection, hyperflexible joints, arachnodactyly, pectus deformity, lens dislocation, downward and nasal. This is in homocystinuria autosomal recessive cystokinine synthase deficiency. Next is cafe au lait spots unilateral polyostic fibrous dysplasia, precocious puberty, multiple endocrine abnormalities, McCune-Albright syndrome. McCune-Albright syndrome is GS protein activating mutation, and clinical presentation is cafe au lait spots unilaterally, polyostotic fibrous dysplasia, precocious puberty, multiple endocrine abnormalities. What is clinical presentation of cystic fibrosis, CFTR defect, chromosome 7, delta F508. So, clinical presentation of cystic fibrosis is meconium ileus in neonate, recurrent pulmonary infections, nasal polyps, pancreatic insufficiency, infertility, subfertility, malabsorption, vitamin deficiency. Next clinical presentation is calf pseudohypertrophy. Calf pseudohypertrophy. This diagnosis is because of muscular dystrophy, most commonly Duchenne, due to X-linked recessive frameshift mutation of dystrophin gene. Next condition is child uses arms to stand up from squat. This is Duchenne muscular dystrophy. Gower sign. Duchenne muscular dystrophy. Gower sign. This Duchenne muscular dystrophy. Gower sign. What causes slow progressive muscle weakness in boys? Slow progressive muscle weakness in boys, Becker muscular dystrophy, X-linked non-frameshift deletion in dystrophin, less severe than Duchenne. X-linked non-frameshift deletion in dystrophin is Becker muscular dystrophy. Next clinical presentation is infant with cleft lip palate, microcephaly or holoprosencephaly, polydactyly, cutis aplasia, seen in trisomy 13 Tau syndrome. Trisomy 13 Tau syndrome, infant with cleft lip palate, microcephaly or holoprosencephaly, polydactyly, cutis aplasia. Next condition is infant with microcephaly, rocker bottom feet, clenched hands, structural heart defect. This is Edwards syndrome, trisomy 18. Next condition is single palmar crease, flat faces, prominent epicanthal folds, congenital heart disease, intellectual disability, Down syndrome, trisomy 21. Next clinical presentation, microcephaly, high-pitched cry, intellectual disability. The diagnosis is cri-du-chat, cry of the cat syndrome, congenital deletion of short arm of chromosome 5. Short arm of chromosome 5, microcephaly, high-pitched cry, intellectual disability. Next clinical presentation is confusion, ophthalmoplegia, and nystagmus ataxia. This is caused by Wernicke encephalopathy, and if you add confabulation, memory loss, and personality changes, it becomes a Korsakoff Wernicke encephalopathy. So once again, confusion, ophthalmoplegia, and nystagmus ataxia is Wernicke encephalopathy. Add confabulation and memory loss and personality changes, it becomes Korsakoff syndrome. What causes dilated cardiomyopathy, high output heart failure, edema, alcoholism, or malnutrition? This is because of wet beriberi thiamine B1 deficiency. Wet beriberi thiamine B1 deficiency. What causes dermatitis, dementia, diarrhea? 3 Ds, dermatitis, dementia, diarrhea, pellagra niacin B3 deficiency.